Good morning, good afternoon, good evening, wherever you are, and welcome to this WHO webinar with the support of TechNet and plenty of partners. Today we'll discuss catch-up vaccination again with a look into insights from 5 big catch-up country case studies. You can listen to this session in English, French, and Arabic. To do so, please click the globe icon that you should see on your Zoom window and select the language in which you'd like to listen to this session. If you don't see the globe, please just check on the more 3 dots. Perhaps you'll find the icon there. We'd be happy to know who's with us today. So feel free to introduce yourselves in the chat box and tell us where you are, where you're from, and your name. You can also use the chat box if you need any technical support, and I'll do my best to help you. If you have any questions during the presentation, we would like you to use the Q&A box. It's actually more practical so that all questions are centralized in one place. The Q&A is available at the bottom of your Zoom window as well. So you look for the icon and use it really at any point. Our panelists will answer your questions in writing during the session, and some questions will be selected to be answered orally, verbally, after the presentation during the Q&A session. Finally, this session is recorded as usual, and we'll share with you next week, or now maybe probably this week. It's Monday, so we should be able to have everything ready this week. We'll share with you the links to the recordings as well as the slides by email. I hope you'll enjoy this session, and I'll give the floor to Daniela. Daniela, the floor is yours.
Thank you so much, Alex, and thank you to the TechNet team for all of your wonderful support. Welcome, everybody. Good morning, good afternoon, and good evening, wherever you're joining us from. Welcome to this session on catch-up vaccination and insights from 5 big catch-up country case studies. My name is Daniela Rodriguez. I'm a scientist at the Alliance for Health Policy and Systems Research, a hosted partnership based at the World Health Organization. I'm your host for today, and I'm going to review for you what we'll be covering today. I'll do a brief introduction of our speakers, and then we will touch briefly on the problem and explaining the how of the case studies. Then we will do country findings from the 5 country case studies and cross-country takeaways. And then we will open to the question and answer period. As Alex said, we encourage you to drop your questions in the Q&A function as well. And then we will have some closing remarks. Before we get started, we want to know where everyone is joining us from. There should be a poll showing up on your screen now asking you, what region are you joining us from? And in part, we want to know not only who's here, but who wants to hear these findings from these 5 case studies. We believe quite strongly that although some of these findings are context specific, some of them are really resonant and transferable to other places. We have almost 100 people online. So we look forward to hearing from you. We have about 70% participation. Maybe we'll get a couple more. Okay. And so with that, I can share with you that most participants today are joining us from Africa. And we have a decent chunk from Europe, which doesn't surprise me. I'm sure some of us are here at WHO based in Geneva and elsewhere. And then a few folks from the Americas, the Eastern Mediterranean region, and Southeast Asia. So with that, let me introduce this overall initiative. The goal of these case studies is to capture the learnings on the big catch-up, this intensified immunization effort that was exacerbated by COVID-19, and then restore the systems. This work represents a partnership between the Alliance for Health Policy and Systems Research and the Immunization, Vaccines, and Biologicals Department at WHO, with generous financial support from Gavi. These are the 5 countries that we will be talking about today. We have a team from the Health Policy Research Group at the University of Nigeria, Enugu, and Brooks Insights in Nigeria. In Cameroon, we had a team from the Evidence for Sustainable Human Development Systems in Africa. In the United Republic of Tanzania, it was the Catholic University of Health and Allied Sciences and Afya Intelligence. In Yemen, building Foundation for Development, and in Pakistan, the Center for Economic Research and RAIN. Our speakers today include a range of personalities, as you'll see here. First, we'll hear from Ariel Higgins-Steele, who is working with IVB WHO headquarters in the Essential Program on Immunization, and specifically on monitoring, evaluation, and learning for the BCU. Then we'll hear from Victoria Ngako from EVEDAF Cameroon, where she is a research officer supporting the BCU case study there. She is also a PhD candidate in sociology at the University of Yaoundé, and she specializes in social development and social safeguards with expertise in gender equity, gender-based violence, and public health. We were going to have Chisom Obijeff from Brooks Insights in Nigeria representing the team. Unfortunately, Ms. Obijeff had a family emergency, and so we are delighted to be joined by Dr. Chinyere Okeke, who is a professor at the Health Policy Research Group at the University of Nigeria in Enugu, who is a co-investigator from that team and will be presenting their findings. Then we will hear on behalf of the Pakistan team from Maki Ahmed from the Center for Economic Research. He is a management consultant with nearly a decade of experience in global development and public sector transformation. He has worked with leading consulting firms to deliver large-scale reform and strategy projects for governments and development partners, and has experience that spans governance, health, and protection, social protection, and economic development. From Tanzania, we have Professor Stephen Mshana, who is a professor of clinical microbiology and infectious disease at the Catholic University for Health and Allied Sciences, and he's also a consultant clinical microbiologist at the Bugando Medical Center. He has served in several committees in Tanzania at the Ministry of Health, Ministry of Education, Science and Technology, and so on. He also is currently serving as the chair of the Tanzania National Immunization Technical Advisory Group. From Yemen, we have Dr. Sheikh Al-Shoteri from the Building Foundation for Development. He is an assistant professor of medical microbiology and immunology at the Faculty of Medicine and Health Sciences at the University of Aden, as well as the research unit leader at BFD. And then our closing remarks will be by Stephanie Shandell from the IVB WHO, who is a technical officer in the Immunization Program Strengthening Team. Her work focuses on immunization policy and routine system strengthening for life course vaccination, including integration of immunization services with other primary health interventions. With that, I will now turn it to Ariel Higgins-Steele to talk about defining the problem and explaining the how. Ariel, please go ahead.
Great. Thank you so much, Daniela, and greetings all. It's wonderful to see such a full house. So in this section, I will summarize the background and the methods for these 5 BCU Big Catch-Up case studies. I think I have controls. Let me just click through. Yes. So in 2020 and 2021, we saw some of the worst continued backsliding in immunization coverage in more than 30 years of global immunization programming. This resulted in large immunity gaps across countries and regions. There's a snapshot of one study here, and there's multiple studies and analyses that show the magnitude by which immunization programs in countries, regions, and globally were affected. So in response, in April 2023, a global initiative was launched by the Immunization Agenda 2030 partners to close the immunity gaps caused by the backsliding during COVID-19 pandemic. The main objective, or the main goal, was to reach and vaccinate un- and under-vaccinated children up to at least 5 years of age. There were 3 primary objectives of this initiative. The first is to catch up children, and specifically the children who missed during the pandemic period, and provide all missing vaccinations to these children. The second is to restore vaccination coverage rates for the current birth cohort to at least pre-pandemic levels. And the third objective is to strengthen systems within primary healthcare approaches to improve program resilience and accelerate towards reaching the zero-dose children in line with the IA 2030 goals and Gavi 5.1 goals and targets. So all of the work of the Big Catch-Up is rooted in theories of change, and this is a theory of change that's really meant to be considered at the country level. So we can see across as a typical theory of change, there's some key inputs country activities, intermediate, and longer-term outcomes. Some of the key inputs, which again look different but are thematically the same across all countries, are having country catch-up plans in place before the initiation of catch-up, financing, so additional funds that were either reprogrammed or used to be able to reach these older children, vaccines, additional vaccines on hand to be able to reach some of the older children, catch-up guidance, and partner technical support. And this then, so all of these different inputs then led to specific activities and the implementation outcomes, which were vaccinating children aged 12 to 59 months and reducing the number of under 5 zero-dose or under-immunized children, and leading ideally to some of the longer-term outcomes of reduced vaccine-preventable disease outbreak risk and strengthening the under 5 routine health platform. So there's more detail here, but you can see that this is a theory of change that's applicable to all the countries and was used in the case studies. So when we come to the specific objectives of the case studies, there are 4 categories. So first, to understand the big catch-up planning, implementation, and monitoring to identify and vaccinate under-vaccinated children. The aspects of integration, so exploring the integration and institutionalization of catch-up activities into routine immunization and primary healthcare services. Understanding the influencing factors, so identifying the contributing factors to the continued existence of individuals who are still unreached despite all of the intensified efforts by immunization services, and understanding that is part of these case studies. And also informing, of course, decisions for better strategies to close some of the immunity gaps and reach children left behind. In terms of the case study methods, the research teams that we will hear from today, they each leverage there was a global case study guidance and sample tools that were adapted to each country context with the tools translated to the appropriate languages. We can see here how the mixed methods of quantitative and qualitative data from both primary and secondary sources maps across the 5 countries, and multiple methods were used for the countries to come up with some of these more robust findings. And I'm sorry, I realize I skipped one slide, which I'm going back to. And this is just to root the case studies within the broader framework of the monitoring and evaluation and learning of this approach. It was anticipated that there would be a number of challenges because of the nature, the complexity, the accelerated effort to reach older children. And so one of the very key aspects, there were different methods that were used, but one of the very key methods and what we're hearing from the countries today are these case studies which provide a deep dive look at within a country context of the experiences, both positive and some of the challenges that the countries are confronting. So with that, we'll end on this case study method slide from my section. And lastly, noting that all of these case studies received ethical approval within their context, and there was a number of different aspects of making sure that the proper data protection of data was adhered to. So thank you so much, and back to you, Daniela.
Thank you, Ariel. Okay, so with that, we're going to move into the country findings, and we're going to kick off with our presentation from Cameroon. Oh, 1 second. We're going to start with the presentation from Cameroon. Victoria, can you please unmute and turn on your video?
Merci, Madame Daniela, pour la parole donnée. Mesdames et Messieurs, bonjour. Je suis Victoria Ngako, membre de l'équipe de recherche pour EVIDAF, dans le cadre de l'étude de cas du Big Catch-up au Cameroun. Et j'ai le plaisir de partager avec vous les résultats marquants de cette grande campagne de rattrapage de vaccination. Le Cameroun, tout comme de nombreux pays, faisait face à un double défi de couverture vaccinale. La présence d'enfants dits zéro dose d'une part, soit 299 654 enfants recensés, et celle d'enfants sous-vaccinés, soit 231 295 enfants recensés. Pour y répondre, le pays a bénéficié du financement de l'Alliance Gavi pour la mise en œuvre du Big Catch-up. Cette campagne de rattrapage vaccinal s'est déroulée sur l'étendue des 10 régions du pays avec une sélection de 80 districts prioritaires. Dans un contexte marqué par d'importantes disparités régionales, des zones difficiles d'accès et parfois une situation sécuritaire fragile. Grâce à cette initiative du Big Catch-up au Cameroun, les résultats cumulés du premier au troisième tour montrent une avancée concrète, soit 30,6% des enfants de 12 à 59 mois précédemment non vaccinés ont été rattrapés sur l'étendue du territoire camerounais. Comment le Cameroun a-t-il atteint ce résultat? Il s'est adapté à des réalités de terrain. Les besoins différents d'une ville à une autre, d'une région à une autre, notamment dans les zones rurales reculées et les régions en proie à l'insécurité. Le pays a donc déployé un éventail de stratégies. Les stratégies postes fixes dans les formations sanitaires dans toutes les régions, les postes fixes temporaires qui s'adaptaient en fonction des réalités de chaque localité. Dans certaines zones, nous avons des postes fixes temporaires dans les chefferies, notamment dans la zone du nord-ouest et du sud-ouest, dans les marchés, dans les écoles. Dans les sites plus difficiles d'accès, comme à l'île, dans les îles, comme notamment Manuka, la stratégie du porte-à-porte a été la plus déployée. Quelles sont les leçons clés de l'expérience camerounaise? Plusieurs leçons ont été tirées du Cameroun, sauf que 3 ont été les plus importantes et les plus marquantes que nous allons déployer ici. La première leçon, l'importance d'un cadre politique existant et volontaire, un cadre politique solide et volontaire. Le Cameroun dispose d'un plan national de rattrapage adopté en 2021 qui a donné une légitimité et une orientation claire à la campagne. La deuxième leçon que nous avons tirée du Cameroun est un engagement communautaire bien marqué. Il s'est présenté non pas comme une option, mais comme une condition de succès. Les agents de santé communautaires, les leaders traditionnels et religieux ont été des relais de confiance décisifs pour atteindre les familles et désamorcer les réticences. La troisième leçon capitale, le numérique est un accélérateur. Le Cameroun a mobilisé plusieurs plateformes numériques, notamment la plateforme IAZO, la plateforme DHIS2, ODK, Cameroun Collect et même Comcare. Chacune de ces plateformes ont joué un rôle capital dans la mise en œuvre des activités et le suivi. Les activités ont été suivies en temps réel, la micro-planification a été agile et était fondée sur les données à tout moment. L'enjeu désormais au Cameroun est l'institutionnalisation de ces acquis dans la durée. Rappelons au préalable que l'institutionnalisation n'est pas la fin de la campagne, mais le début d'une vaccination routinière plus inclusive et résiliente, capable d'atteindre durablement chaque enfant partout sur le territoire camerounais. Dans cette mouvance de pérennisation, quelles sont les priorités pour une institutionnalisation réussie au Cameroun? Quelles priorités ont été identifiées? La première priorité, une intégration budgétaire nationale via le budget de l'État. Nous savons tous ici que le Big Catch-up bénéficie d'un financement qui est ponctuel. Après la fin de ce financement, que devient la couverture vaccinale au Cameroun? Il est nécessaire et il est même indispensable qu'une intégration budgétaire soit faite dans les planifications budgétaires du Cameroun. Il est également important que les stratégies mobiles soient pérennes. Le Cameroun, comme on l'a mentionné tout à l'heure, a des zones très difficiles d'accès. Et également, il y a une insuffisance de formation sanitaire dans certaines zones et même parfois d'absence. Ce qui fait que pour pouvoir atteindre durablement les enfants zéro dose ou sous-vaccinés, il faudrait que les stratégies mobiles soient pérennisées. La troisième priorité ici, c'est la formation et la motivation continue des agents de santé communautaire qui jouent un rôle central dans l'adhésion vaccinale des populations. Nous avons également les leaders traditionnels et religieux qui doivent être intégrés à tout temps dans le système de santé camerounais. Nous marquons également un point d'ancrage sur la chaîne de froid et logistique qui doivent être renforcés, notamment dans les zones reculées et en contexte d'insécurité. Les zones reculées ont ceci de particulier que généralement, elles n'ont pas un système d'approvisionnement en électricité. Et il faudrait à chaque fois renforcer cette logistique-là et s'assurer que les vaccins ou les antigènes sont conservés dans de bonnes conditions. Une autre priorité à prendre en compte est celle de la gestion des rumeurs et une communication ciblée. Chaque zone a ses réalités et on devrait adapter la communication en fonction des réalités de chaque localité. Pourquoi ne pas communiquer en langue locale pour certaines zones où la langue française n'est pas du tout accessible pour la langue anglaise? Nous avons également l'harmonisation du système des données. Pour pouvoir mieux gérer les données qui sont collectées sur les différentes zones, on devrait harmoniser ce système de gestion des données, notamment dans les zones qui ne sont pas couvertes par l'électricité. Les plateformes numériques sont certes une aubaine ou alors certes une priorité, un catalyseur, mais elles devraient prendre en compte également les zones qui ne sont pas couvertes par l'électricité. Comme énuméré si haut, le Cameroun dispose d'atouts solides pour transformer le Bicatop en une composante pérenne de son système de santé. Une volonté politique est marquée, des partenariats opérationnels avec les acteurs de la société civile sont également connus, des outils numériques de base et un ancrage communautaire solide. L'opportunité est là, passer d'une campagne ponctuelle à un système résilient et inclusif. En résumé, l'expérience camerounaise pour que chaque enfant, où qu'il soit au Cameroun, ait accès à la vaccination, pas seulement pendant une campagne, mais tout au long de sa vie. Je vous remercie pour votre attention.
Merci beaucoup, Victoria. Thank you so much. And thank you for those very thoughtful findings from Cameroon. With that, let's turn our attention over to Dr. Chinyere Okeke, joining us from the Health Policy Research Group at the University of Nigeria in Nugu.
Hi, good afternoon, everyone. I'm here to present on behalf of the team the big catch-up case study findings in Bauchi and Rivers State, Nigeria, where we worked at the subnational level. Sorry, next, please. Okay. So the study sought to examine the big catch-up planning, implementation, and monitoring across all levels in Bauchi and Rivers States to sustainably reach zero-dose and under-immunized children as part of immunization and the primary health care services. So Nigeria has an estimated 2.1 million zero-dose children with an immunization coverage rate of 53%, as stated by our National Demographic Health Survey 2023 to 2024. The Nigeria's big catch-up routine immunization intensification seeks to reach and to vaccinate on and under-immunized children up to at least 5 years of age. The big catch-up was conducted across 200 prioritized local government areas in 30 states and the Federal Capital Territory of the country. And this happened from December till April last year, December 2024 to April this year, targeting children that are 12 months to 59 months old, and we used both fixed outreach and mobile sessions to reach them. The approved big catch-up antigens were the pentavalent vaccines, 3 doses, the oral polio vaccines, 2 doses, and then the inactivated poliovirus vaccine, 2 doses, and the pneumococcal conjugate vaccine, just 1 dose. So in Rivers State, we had 11 local government areas joining the big catch-up activities, while in Bauchi State, only 2 local governments were selected. So we could see the dates when the rounds happened. In Rivers, we had the first round in December 2024, and the second round in February, while the third was in April this year. While in Bauchi, similar timings, first round happened in December, we had the second round in February, and the third round in April this year. So the target population for Rivers State was to reach 281,198 children. which is about 65%. And the BC, that was the general population targeted of zero-dose children. And the BCU specifically targeted to reach or exceed 65% of that population, which is 182,779 children. While in Bauchi, the target population was 8,773 children, and the BCU target was to reach 25,202 of such children. So for the BCU case study, we selected 3 local governments per state, and it's based on the wards, the zones, and a lot of factors, large and low performing areas. The BCU case study in Rivers State was conducted in Andoni, in Brunei, and in Port Harcourt local government areas. While in Bauchi, it was the 2 local governments where the BCU happened, which is Bogoro and Kerfi. But then we had to add a 3rd local government based on the request of the state, the Misao local government. So it's a non-BCU local government, but it helped them compare their activities and gave insightful findings. Okay, so we now look at the community engaged planning. We had multi-strategy delivery. We had real-time monitoring and tailored strategies that successfully helped us reach these zero-dose children despite no formal institutionalization of the big catch-up activities in the country. So for the planning, we had some key lessons learned, like utilizing the existing immunization governance structures. This ensures sustainability and integration with the routine services. We also had strong multi-stakeholder collaboration with government, with partners, and with the communities, and this was critical for the success recorded. We had detailed catch-up micro-planning, geospatial mapping, and active community involvement, and this informed resource allocation and identification of the zero-dose children settlements that had been missed in the past. We had systematic vaccine distribution planning, including forecasting and allocation systems, and these were based on the facility needs and the facilitated supply availability. So that was for planning. For our BCU implementation, we engaged community groups for door-to-door mobilization. The traditional and religious leaders were all included from the micro-planning stage. The supervision and community dialogues happened prior to immunization and even during the implementation. And this contributed to overcoming some of the social and cultural barriers that were the main reasons why these children were zero-dosed in the first place. We also had multi-strategy approaches by using the fixed method approach, the health centers, we used outreach, and then mobile home-to-home people giving the immunizations. With community groups, we had the mama-to-mama, and they helped effectively reach these zero-dose children. They were also adjusting fixed post schedules. So most of the health centers had to adjust their timings to either start very early in the day or continue to very late in the night when those that had gone for farms and other activities will be back, or some market days, just to accommodate and ensure that they come for vaccinations. And then there were early morning outreaches during the farming sessions to address the access barriers and transform service uptake. There were also use of phone reminders, community dialogues, and these address forgetfulness, which we found as one of the major reasons or barriers for children getting immunized. And it also helped to motivate them. Then we had the daily evening review meetings. This enabled real-time problem solving and rapid adaptation, since all the supervisors and all the people concerned were meeting daily every evening. Then for the monitoring of the big catch-up activities, we had real-time digital data collection using the Google Sheets and the Open Data Kit, ODK. They provided immediate visibility for rapid daily adjustments while they were still in the field. We had ward data validations before the DHIS2 upload served as quality control mechanisms. We also had standardized supervision checklists, and these facilitated systematic supervision and quality assurance during the implementation period. So what are the root causes of zero dose and under-immunized children in Nigeria? Some of our findings were linked to persistent interconnected barriers that contributed to having zero-dose children. And these included their thinking and feeling, they had knowledge gaps, there are misconceptions, the adverse events following immunization were not well addressed, so it made most of them not to continue after receiving the first dose. Mothers were not willing to bring their children again. There were caregiver forgetfulness. There was focus on children when adults lacked basic health care, so the adults could not understand why we are always pushing immunization to them in the communities. Then there were also social issues like the religious beliefs, spousal or mother-in-law disapprovals, and in most cases, these are strong, significant others in the communities. And then there are communal clashes that prevented some of our immunization teams to reach the designated areas, and the nomadic lifestyle, which is prevalent in some aspects, some parts of the communities. We also had some practical issues like the geographic challenges. There are some very hard to reach areas, and they had high transportation costs trying to reach them. Like some, you had to go through rivers and boats, and it's not easy to have access to them. There were also healthcare worker shortages and poor attitude of the healthcare workers, even when these mothers come. And then the mothers also complained of long waiting times whenever they come for immunization. Okay, so what would Nigeria do differently if we plan for big catch-up again today? So it will be to redesign the big catch-up as a permanently institutionalized, government-owned routine immunization intensification service with sustainable funding, strengthened health systems, community involvement, and tailored strategies. So we hope to design and communicate BCU as an intensified routine immunization activity that is integrated into the routine services rather than a time-bound campaign. So we also plan to have a comprehensive address of the geographical barriers by having more health posts in those hard to reach areas or even never to reach areas. Some places are designated as those. And then deploy dedicated outreach teams with appropriate incentives so that they will make the extra effort to reach those places. We also intend to develop and implement tailored evidence-based strategies to address the root causes of vaccine hesitancy that undermine vaccine uptake, and these are very necessary if we hope to reduce our zero-dose numbers. First is the adverse events following immunization. They need counseling and rumor management strategies by use of banners and town criers and local strategies to make sure that people hear. We also need to sustain our engagement with the community leaders, and the community dialogue sessions should happen frequently to address specific myths and misconceptions. And then we should work to integrate trusted community programs alongside immunization programs and tailor our messages specifically for some groups. If we know those that are the higher contributing highest to zero dose, we could reach them. Engage and formalize community resource groups to address these community mobilization needs, like the use of Mama to Mama in Bauchi and Fathers to Good Health. Fathers for Good Health, these were found to have been very helpful. So despite the absence of a formal institutionalization policy and plans, there are some promises. However, participants identified systematic barriers to achieving institutionalizing catch-up activities. So what are these current plans? We plan to integrate the catch-up from both states, incorporating them into the state annual operational plans, ensuring that government counterpart funding contributions towards immunization, and positioning the catch-up activities as routine immunization efforts rather than as campaign activities, as seen in some of the quotes here by our respondents. So what are the main challenges or concerns around institutionalization? The main is the multiple systematic barriers that prevent institutionalization of catch-up activities, things like absence of a formal policy to continue this catch-up. We also don't have operational framework for integrating these into the routine immunization and primary healthcare services. And then there are health workforce shortages and logistic costs that we have to identify who there, and unsustainable community efforts without compensation mechanisms, as most of the people are volunteer workers. There is also limited geographic coverage of catch-up activities and infrastructure gaps, including inadequate coaching equipment, as we found in some health facilities, inadequate communication strategies, uncertainty about sustaining the funding and the future supports of catch-up activities. Okay, next slide, please. It's not moving. Okay, so the institutionalization opportunities include integrating the catch-up into the periodic intensification routine immunization activities and into the primary healthcare services, leveraging our annual operation plans and community structures, and expanding the DHIS tool, which is a reporting system used in the country, but it does not capture for children over 2 years, and then aligning all these with the national policies. So some of our respondents had echoed this, and what will it take now to reach zero-dose children on a regular basis? So we are saying that sustained financing for outreach services, for transport support, and community mobilization activities, including providing continuous education on the importance of vaccination and adverse events following immunization counseling to the caregivers, as well as community dialogues to counter most of the misinformation and conspiracy theories. We also have health system investments, if we can have that in our country, especially in personnel, to bridge the shortage of healthcare workers and also help in the vaccine supply chains. It will be helpful. Also, operational flexibility to adapt service delivery strategies to community realities, like adjusting these fixed post vaccine schedules that were done during the big catch-up. It could become a routine thing. And then we can have systematic tracking and follow-up mechanisms for our defaulters, but that needs dedication at the health center level. Are they able to remind them on phones when we collect their numbers? Or do we have real-time digital data systems that are showing the defaulter lists early, and then the community-based door-to-door follow-up to ensure completion of vaccination schedules? Thank you very much for listening.
Thank you so much, Dr. Okeke, and thank you so much for stepping in at the last minute to talk us through the results in Nigeria. So with that, we will now turn over to Mr. Ahmed Maki from Pakistan to present the results from the Pakistan case studies. Make sure that, there you are, and you are ready to go. Go ahead.
Hi guys, this is Ahmed Maki, and I am representing Center for Economic Research Pakistan and RAIN Group. Together as a consortium, we did the evaluation of BCV in Pakistan. So in the next 8 minutes, I'm going to summarize the key learnings and findings from our evaluation. I've tried to keep the slides brief, but if you have any questions, please do drop the question in the Q&A part. Okay. Yeah. So very quickly on the immunization landscape of Pakistan. So Pakistan is a big country with almost 240 million people, which means We've got a lot of zero dose children also. So about 400,000 children are zero dose in Pakistan, and millions of children who are under immunized. We did our evaluation in Punjab and Sindh. You can see the Punjab province here, which is mostly green, which is the full immunization rate. It's not 100%, it's between 80 to 100%. The overall immunization rate of Punjab is about 89%. And we did our evaluation in Sindh also, which has between 50 to 80% FIC rate. So it was a good contrasting evidence for us on both sides of the argument. So in Pakistan, the immunization service delivery is done through the EPI, which is Expanded Program on Immunization, established in 1978. The BC implementation in Pakistan started in March 2024 through a national working group meeting at the national level. And the meetings were headed by the Prime Minister of Pakistan, not headed by, but supported by. And then through a cascading model, the instructions were conveyed down to the provinces and districts. And then finally, the first round of BCU was conducted in October 2024, right? So very quickly, three key learnings which would be useful for everyone here. The first part is the very detailed and fine planning carried out in Pakistan. It has two unique parts. The first part is, as I mentioned earlier, there was a lot of ownership at the national level, at the provincial level, at the district level, which meant that the groundwork had very solid instructions and very solid monitoring and very solid supervision by senior officials, right? So everything was cascaded down through a very finely tuned cascading model in which you had the meetings taking place at the national level, then the instructions were given at the provincial level, and then provinces carried out their own planning at the district level, and the districts then carried out their own planning at the UC and facility level, right? So the planning model is actually good learning for Pakistan for such campaigns in future. The second part was target setting, which had multiple perspectives. The first part was the target setting initially was carried out through Vunic derived targets, which was calculated through the population rate and the immunization rates. That did not clearly correlate with the bottom-up planning carried out by the districts, right? So that is a learning essentially for countries and for Pakistan that the targets need to be corroborated by the ground teams also, right? The second part of the targets is provinces made efforts to revise their targets, right? So in round one, the targets were mostly Vunic derived, but after that, provinces use their own micro planning, continuously revise the targets based on people coming in, people left out, the zero dose population, and the changing monks, which meant that you need to adjust the targets for newer populations, right? So a very dynamic approach to target setting was carried out. And the third thing is the mobilization and the outreach model. Here we have three parts. The first part is the mobilization was well appreciated by the vaccinators, in which the vaccinators are provided with two community mobilizers who would go out, mobilize the children, and bring them to the outreach site. So Pakistan has fixed sites and outreach sites. Outreach sites are set up in the communities, and vaccinators appreciated the support that were given to them in the BCU rounds. The second part was generally, in order to have better outreach, you need to have more vaccinators, but Pakistan has been struggling with, and which is common to both provinces, Punjab and Sindh. We've got a shortage of vaccinators. And the third point reflects that the government is actually trying to fill this gap through very dynamic models by leveraging help of the development partners, by having evening outreach sessions, by providing more fuel support and transport support to the existing vaccinators, right? So it's trying to bridge the gap, and we've got good stopgap arrangements, but essentially we can solve the complete problems if we have more vaccinators, right? So these are the major learnings. And let's talk about institutionalization. So we've got three points here. The first part is Pakistan was able to officially introduce the higher age group in its planning, in its operation, in its implementation. So provinces made good efforts and revised their operational models to vaccinate higher age groups, which means that they now have good understanding about how to vaccinate higher age groups. If a 3-year-old child or 4-year-old child comes in, what vaccine to give to that child. So officially, Pakistan is equipped now to deal with higher age groups. And one very positive thing that we learned from both Punjab and Sindh is that they are now completing the schedules of the 2 to 5-year-olds who came in the BCO rounds. They are not being turned down. So if a child, 3-year-old or 4-year-old who was vaccinated in the last BCO round, if the child comes today to seek the remaining vaccination doses, the remaining antigens, that child is vaccinated, right? So the higher age group has been officially introduced. It's not systematically implemented because it depends on the amount of vaccine available and the funding available, but the system itself is ready to deal with the higher age group, right? That's the first part. The second part is the data systems have been expanded. We initially found out that the provinces are using WhatsApp group or some Google Sheets to record the data for higher age groups, as the EMR system did not have the higher age group features. But later on, the EMR systems for both Punjab and provinces were changed to accommodate for the higher age groups. Now, in future, if Pakistan were to officially introduce 2 to 5 vaccination again, then the system does have spaces and features to record the higher age groups, right? And the last thing is the micro planning has been expanded. The vaccinators, the social mobilizers, and the teams on the ground, the district officials have actually learned how to make targets for higher age groups. Now they know how to rely on the LHW diaries, they know how to rely on the polio campaign data, they know how to rely on the vaccinator data. Now, so they've been officially taught and trained how to develop good targets for the higher age groups if they were to vaccinate in future, right? And the last thing, which I'll do in the next 1 minute, less than a minute, is the perspective of the leadership and the district officials and the vaccinators on making BCU as a permanent part of the routine immunization service delivery. The provincial leadership thought that BCU was useful, but it should not be done as a separate campaign or a separate activity. It should be integrated in the routine immunization activity, but because it's going to provide some burden on the financial resources of the provinces, right? So rather than having separate campaigns, we should have like fully integrated routine immunization system that has resources, both financial, operational, vaccinators, social mobilizers, more vaccines to deal with the higher age group, right? No separate campaigns, built in the whole system. That is what they want. Second thing is district administrators. So these are the guys who were actually implementing in their districts, and they kind of pointed out the operational part of the problem, which was interesting to find out that they said we had to do more monitoring, we had to do more supervision, and we had to mobilize more resources for 2 to 5. We can do that for 0 to 2, but in order to do for 2 to 5, we need more support. So rather than having more separate campaigns, let's make it part of the routine immunization system with more resources. And lastly, on the vaccinators, they actually appreciated the support that was given to them in the campaign, which is they got social mobilization support. Usually, this support is not readily available to the vaccinators when they go out to vaccinate children in the streets on their outreach sites. But during the BCU campaign, it was provided to them. So they were able to meet their targets, 0 to 2 age groups, and for 2 to 5. So they appreciated the support, and they were able to vaccinate more children also, right? So these are the major perspectives of the different stakeholders. Well, thank you very much. That's about it.
Thank you so much, Maki, for talking us through the findings from Pakistan. And with that, we will turn over to Tanzania, where Professor Stephen Mshana will be presenting the results from their work. Okay, Professor Mshana, take it away.
Yeah, thank you, Daniela. I'm presenting on behalf of Tanzanian team. So I'm going to summarize the finding from Tanzania case study. Yeah, in Tanzania, which is a large country, the immunization program it's really contained 9 vaccines, presenting 14 vaccine-preventable disease. And the program used the DTP3 as the proxy indicator. What it was noted in 2021, number of districts with the coverage of DTP3 of more than 90 dropped from 170 to 144 in 2021. And the number of districts with DTP coverage below 80 increased from 80 to 20. So this was noted. And in 81 councils, there is about 195 councils. The total of 1.1 million children aged 12 months were identified as having 0 doses. So between 2022 and 2024, Tanzania implemented big catch-up as part of global strategy to routine immunization. So they did like 3 rounds to try to catch up those children who had under or at 0 doses. And this was done in 7 selected regions out of 31 administrative Tanzanian regions, and 16 district councils were involved. And 61 health facilities were reached, and it managed to survey 281 healthcare workers and about 900 caregivers. And this followed the big catch-up guideline to evaluate what was done to reach those children. So what did we learn and what can we do differently, especially if we are given a chance to do again these big catch-up activities? So what we noted, BCU planning was not comprehensive with suboptimal engagement of subnational level implementers. And this was acknowledged by manager who say coordination gaps exist, so it was difficult to appropriately budgeting to ensure that the funding available in the process lead to revising of microplan to ensure successful of the program. And also during implementation and monitoring carried out thoroughly, because some of the gaps were not timely identified, like they missed some information in the cards and the unsuitable vaccination schedule, a lack of daily vaccination services in several health facilities, and the understanding about the target of the vaccination. So all these were noted. Also, it was not some discrepancy with targets and children reached with the Penta 1. And this was really noted and highlighted by managers and the front health workers as a critical component of catch-up vaccination activities. And also data discrepancy was noted. And this variation really was due to functionality of data across distant timely availability of standardized tools to ensure the collection of the quality data to monitor the program. So these are the issues which were noted and could be done differently. But Tanzania Immunization Register has been piloted in some countries in Tanzania to track individual level vaccination. This can be countrywide instrumented to capture quality immunization data to monitor the program. So this is a lesson learned that the availability of this tracking system we can do differently in relation if we given another chance. Then there is the ongoing revision of national immunization strategies guideline, and this have incorporated some issues regarding strategy to capture unvaccinated and unvaccinated children. So it's an issue which also can be considered. But something else which was noted is some contextual and environmental factors, such as access to vaccination services, such as availability, human resources issue regarding geographical issues. All these were not well considered at the beginning of these activities. And the other issue related to caregiver factors were also not considered well during the implementation. And this can be done differently if we have to do this again. The issue regarding plan implementation and monitoring will be done different by ensuring first availability of realistic targets with the quality tools to monitor and track the progress over time and timely intervention to address those issues.
Stephen?
It's not, the slide is not moving.
How about that? Your video is frozen, but we can still hear you. I've advanced the slide. Please go ahead.
Yeah, okay. Now, regarding institutionalization, so one of the issues which really worked well and has been institutionalized in Tanzania is the engagement of community healthcare workers. So the detection and the referral of zero dose and the vaccinated children has been formalized. And the training package of community healthcare workers has included the issue regarding how to catch up and to identify these children. In addition, the catch-up of zero dose and unvaccinated children has been included in the revised national immunization strategy. And this has focused especially to ensure microplans at council level have some strategies to reach these children. But the other things which have been well and will be well considered in this is the encouraging councils to allocate some funds so that we can maintain the skill of health workers and improve service delivery to ensure they really identify and reach these children. But the other issue is the training. So integrated training to ensure instead of focusing on single vaccine, that the training captures some of the hurdles and some of the other issues which are related to service delivery so that to well equip the healthcare workers in the skills and competence.
Oh no, it appears that Professor Nchana has been disconnected. So I will take the opportunity while he reconnects to just give you a chance to review what he's discussed here. There's obviously issues around for institutionalization of big catch-up around councils allocating the necessary funds. And there are other concerns around how to finance the intensity required for routine catch-up and the fact that they'll be relying on individual councils' planning. In terms of the monitoring and institutionalization elements and how those have been institutionalized in 2025, the data tools were updated to track children beyond the routine vaccination age, and they've been now grouped between under and over 1 year. And starting at the beginning of 2025, the vaccine information management system was revised to record vaccinations around target age. To reach zero-dose children long-term, those strategies need to focus on community education and awareness in collaboration with local leaders, and then improving vaccination service availability through context-based microplanning and improved data tracking and follow-up. And on behalf of Professor Mshana, we want to thank the overall team at KUHAS and with Afya Intelligence that did all of this work in Tanzania. So hopefully Professor Nchana will be, I see he's just joining us now. So as he finishes connecting, maybe we'll be able to have him for the Q&A. And with that, we're going to move on to Yemen. Dr. Sheikh?
Okay. Thank you very much. Good morning, good afternoon, good evening for everyone who is in any place in the world. I am Dr. Sheikh from Yemen. I am trying to present the big catch-up case study finding in Yemen. Our country at this time is living in conflict. Is living in conflict. We have divided the country into parts, north and south. So all the economy and the social service is decline. The immunization is also very low during this time from 2019 to 2024. We have see the decrease in the coverage of routine immunization to less than 50% in most of the vaccines. So in Yemen, a lot of zero doses children have accumulated during this period, and we have for the immunity gap lead to recurrent outbreak such as measles, diphtheria, polio, and cholera. Big catch-up can help to decrease the immunity gap. The coverage result for our country, which is started in September 2024, is still low. But we see improvement by time. Until July 2025, the national coverage for target children 12 to 59 months show 7% for Binta 1, 3.6 for Binta 3, and 18.2 for MCV 2. This is for national, but in the southern part of Yemen, which is more improved, the coverage rate, which increased to more than 10% in most of the vaccines and 25 for MCV2. Southern Yemen Governorate also show regional differences in coverage rate. We have some area achieving higher rates, about 50 or more, and some governorate is very low, such as Socotra, Seyun, and Abiyan with low coverage, but Al Hudaydah, Al Dal, and Aden showing higher coverage. The BCU primarily utilize fixed facilities, outreach activities, and mobile team. We have learned a lot of lessons from the PC4 planning. We see that one size fits all plan does not work. Micro planning must be hyper contextual. For implementation, it is incredibly challenging to deliver multi-dose vaccine, especially Binta and IBV, through a catch-up campaign, but it is easier for measles rubella vaccine. For institutionalization, catch-up must be designed for the routine system from the start, not bolted off on afterward. For zero dose, the most important thing that reaching the last mile require more than just vaccine. It requires trusted community, network, and solving access barrier permanently. What to do differently? We must integrate catch-up into continuous routine immunization activities from the beginning, not as a separate campaign. And also, it is important to prepare the community through awareness, correction of misinformation before each campaign. This is important because without trusted community, we cannot have good coverage. Institutionalization catch-up activities, the big catch-up now integrated in the National Immunization Strategy 2025 to 2029, and it is part of the policy. At this time, there are a dedicated governance body. It is the steering committee, which supervise the catch-up initiative and ensure integration with routine immunization. Standardized SOP for BC activities embedded in routine immunization standard operating procedure, including eligibility check, dosing schedules, and catch-up algorithm. Use of routine immunization platform, fixed site, outreach, and mobile team for catch-up doses at this time. All the activities is integrated. We have good coordination between the different health programs, which provide other services and also immunization as part of this program. Updated recording and reporting tool with inclusion of big catch-up data in the routine immunization information system, the registries, the district health information system, and other digital tools. What is the challenge? Challenges for institutionalization, it is the conflict, ongoing conflict and access constraint, limit campaign, scheduling, and supply flow. We have also insufficient funding, especially in the future. At this time, we have the fund from Gavi and the WHO and UNICEF, but in the future, there are no any local resources for sustainability, and also we have understaffing and problem in the cold chain. The most important is dependence on donor cycle with potential gap between funding periods. We have also fragmented and low quality data. hinder accurate macro planning and performance assessment, especially in country with there are no any population data recently. We have depend on old data and they are not take in account the movement and displacement of the population when they calculate the target children in the different zone. The opportunities in integrated outreach activities include immunization with other health services such as nutrition, child health, and maternity health. We have also community network of more than 50,000 community healthcare workers, volunteers, community midwife, and others who can play an important role in tracing the zero dose and defaulter and refer them to vaccination centers and play a role in awareness campaign. Use of electronic vaccination record, which is piloted in 3 governorates at this time. It is helpful and will use to follow up defaulter and send reminder message to caregivers.
Thank you so much, Dr. Sheikh.
Thank you very much.
Thank you so much, Dr. Sheikh. And I want to thank all of the teams for sharing with us their findings so far. I want to note that these are very, very rich case studies of which you're only getting just the slightest little touch. And so I'm going to do a little bit of work here trying to synthesize some of the cross-country learnings that we have identified with the teams and the focal points. And we encourage you to read through the individual country reports as well as the global reports once they're available later this month. So a few lessons to remember, to sort of take away. In terms of the achievements of the big catch-up, children who otherwise would have continued to be missed received at least one missing dose of vaccine. Now, how many of those kids and which doses and which vaccines obviously varied by context. The big catch-up and catch-up generally have strong buy-in across stakeholders. And the BCU provided an opportunity for more engaged planning and implementation across all levels of the health system. Now, one of the things that's important, and we heard from several of the countries, is that the starting point targets that were established were not aligned between the global and the local level. And that has meant both differing and evolving targets and difficult explanations and narratives to explain what has been achieved or not. We also see some progress around some of the systems enablers for catch-up. So whether that is revised catch-up schedules, establishing standard operating procedures, having training materials and tools, all of those things, changes to recording and reporting systems, those are assets that remain. Some implementation lessons that remain here are that all of the case study sites used multi-round campaign-style implementation. Even though that wasn't necessarily the recommendation, this was a familiar approach, and it aligned with the ambitious targets and rapid timelines that had been associated with the BCU. We saw countries had a substantial variation and flexibility in their operational modalities. So whether it was fixed or mobile outreach or having different times and days, going to special sites, going door to door, aligning with other activities in the community, such as the agricultural cycle. That kind of flexibility really evidences the kind of adaptive management that we hope health systems will demonstrate at all levels. At the start, certainly some systems were not fit for purpose for the BCU. So whether that was data reporting and monitoring tools and systems that couldn't account or disaggregate different ages of children, job aids that weren't available in enough quantity or in the right languages or on time, and funding being unavailable or being dispersed late were all issues. We did see that in some settings there was coordination or piggybacking with other initiatives to increase uptake, and that varied by setting. In some places they offered other vaccine services like vaccines for adults as well. They were linked to financial incentive programs or outbreak response. And then in terms of takeaways here for the future, we have a few big ones to think about. The first one is that despite the progress that was made on the system side, we still have to contend with the longstanding systemic challenges that predated BCU and are going to continue. So whether that is staff shortages and overburdening, insufficient funding, especially for outreach, misinformation and awareness, not only among families, but also around providers, all need to be addressed. And some of those issues will be even more challenging as you start to institutionalize catch-up. So for example, how do you dynamically forecast, procure, and distribute vaccines as the needs change on a regular basis? Similarly, updating the microplans for hard-to-reach groups it's quite resource intensive in a lot of ways, and that can be difficult to do regularly. We all know and agree campaign style is not sustainable. At the same time, that outreach and intensification required to regularly reach these kids that are being missed could also be difficult to sustain. Bringing immunization services closer to communities is something we know and we hear about a lot. Through scheduling, outreach and intensification can be planned and adjusted for to be able to support not only on-time vaccination, but also catch-up vaccination where needed, but also with available resources. And lastly, decentralization in these health systems is going to play an even bigger role for immunization going forward, especially now with these changes in overseas development assistance. More attention is going to be needed because subnational governments, whether it's at a provincial, regional, district level, have more roles and responsibilities around resourcing immunization programming, and that is going to be important to keep in mind. So with that, we're going to turn to the Q&A. I'll stop sharing my screen. I'm going to ask all of our panelists to please turn on their videos. And then I'm going to ask my colleagues who have been dealing with the Q&A in the chat to help us navigate the discussions. I will say that as I was managing the presentation part, I wasn't able to keep track of the Q&A. So hopefully we have a number of questions that have already been answered. I see that I see a question for Cameroon around the hit and run strategy. And then a question for Yemen around the drive for integration and what that means for that particular setting. So with that, I wanted to see, and I see some questions in the chat about sharing the presentation. Yes, the recordings definitely will be made available. And so anyway, let's turn first maybe to the Cameroon team. Victoria, can you hear us?
Merci, Madame Daniela, pour la parole. Madame Ariel parle de la stratégie délit de fuite. Je crois que c'est un peu une incompréhension. C'était plutôt la stratégie hit and run. Hit and run qui a été mobilisée dans les zones de conflit et plus précisément à haut risque, notamment dans les régions du nord-ouest et du sud-ouest. En quoi consiste cette stratégie? Il est question de mobiliser une équipe solide, une équipe mobile solide, incluant à la fois l'équipe de vaccination elle-même, mais aussi des leaders locaux et ou les forces de sécurité pour aller vacciner rapidement le maximum de personnes possible dans une zone à haut risque d'insécurité et repartir. La particularité de cette stratégie est laquelle? Elle requiert la présence de ressources humaines locales parce qu'on doit connaître les populations qui viennent vacciner, mais aussi et surtout un temps de vaccination très court et limité pour minimiser l'exposition au danger. Toutefois, avant toute descente sur le terrain, une mobilisation communautaire est requise pour se rassurer de toucher le maximum de personnes possible. Merci.
So thank you so much, Victoria, for elaborating around the use of the hit and run strategy in conflict zones. This idea of sort of coming into an area, trying to gather kids as much as possible, reaching as many as you can, and then stepping away in order to reduce the risk to providers. Thank you for that. We have a few questions for the Yemen team. Dr. Sheikh, there's a question here about the driver integration and how that's working, and also about if you could elaborate more on why Penta and IPV were harder to deliver than MR. Over to you.
Okay. About the injectable vaccine, especially for the older children, is not highly accepted by the caregivers. And they see that after giving the injection, the older children have pain and immobility, and this lead to concern. Also, the healthcare worker is not trained good in how to explain to the caregiver about the natural response, which is lasts only a few days and will terminate. But also when they have no explanation and they don't give them advice on how to manage this side effect, the caregiver will not come again, especially for the next vaccine. I see many of the vaccinators who are not knowledgeable in how to inform the caregiver about the side effect and to convince him that this side effect is transient and the danger of the disease is more than is a big. So to convince them to take the vaccine. We need to train more training to the healthcare workers, vaccinators especially, in how to explain to the caregiver about the side effects. Because if they don't explain for them and he see that his child not able to move or have pain, they will not return again. So this is one problem, especially for the older children, which in some districts they try to call the vaccinator who have no experience to how to answer their concern and correct this concern. About the integration, we have good integration at this time. Our immunization activities is integrated with many health services, with the child health and also maternal health, and there are good cooperation between the different health programs, referring the child who are not vaccinated to the vaccination center. So although the coverage rate is low, but I think the progress is good. We have seen improvement, and these data are about the coverage is until the July 2025. But we have also 2 rounds integrated around outreach round done in August and November, and I think these 2 activities will increase the coverage rate. But the most important thing is that all the big catch up at this time is included in the immunization strategy, and we have also all the record and reporting tools, big cut up integrated in the system. And we need to strengthen the routine immunization instead of the campaigns to improve the routine system and the primary healthcare to in the future, in order to be the service sustainable, and we must enforce the community healthcare worker in the process of tracking and education of caregiver. Thank you.
Thank you so much, Dr. Sheikh. And there's a question in the chat that I'd like to direct to Prof. Mshana and Maki and others if we have time, which is around caregivers and how, as they experienced BCU, whether that changed their attitudes around future vaccination. What did you hear from whether it was the focus group, the qualitative methods that you used, or the quantitative methods? Prof. Mshana?
Yeah, thank you, Daniela. From the caregiver survey and the focus group discussion, what we noted in Tanzania, their perception regarding vaccination were very high, with a few of them complaining regarding injection, but generally the perception were high. The only problem during focus group discussion in the survey is the availability of vaccination services. For them, they really want a lot of flexibility regarding to vaccination services. For example, for Tanzania, when they go for their services, they don't want to be told that today we are not giving vaccination, or this antigen is out of stock, or what. So this is really their big problem. But so it's an opportunity which can be used by the program, because we didn't experience much the issue of hesitance and the other things. So it's an opportunity for health system to be strengthened to ensure the availability of services, because they are ready for that. I think that is what I can say in summary from Tanzania perspective.
Great, thank you so much. So it sounds like there's certainly demand from caregivers and families, and then it's a question of having the supply, the system meet that demand. Maki, any reflections from Pakistan?
Yes, very quickly on this. So the caregivers we talked to, they were interested in vaccination services generally. They were interested in continuing the vaccination services for their high-risk groups also. The sample we had did not include many zero-dose caregivers. The problem with Pakistan is that if someone does not want vaccination, then they would not want all vaccination. It's not a matter of, hey, I want this one or not that one, right? It's just a matter of take vaccination or leave vaccination altogether, right? So the ones we spoke to were very interested in vaccination, and for if they missed their vaccination, then they were interested in continuing also.
Great, thank you so much. And Dr. Okeke, I don't know if you can hear us, but I don't know if you can, if you have any
Yes.
reflections from caregiver perspectives in Nigeria, that would be great.
Sorry, please come again. I didn't hear you very well.
Sure. So we had a question from the audience about caregivers that were reached by the BCU, whether that made them want more vaccinations after that experience.
Yes, because with the whole communication strategy that was strengthened during the BCU activities actually threw a lot light on people and informed them of some of the misinformation and mistrust issues and all whatnot, all the myths were laid. So they were now willing to come. And then when you already have informed someone what to expect, like the adverse events following immunization, so when it comes, it's not like a surprise to them. So the problem is when they see this for the first time, bringing a child, and they see this, they don't want to continue the doses. Some others even hear from their friends, and then they don't even want to go at all, thereby increasing the zero-dose children. But with and after the BCU, I'm sure people are more willing. The communication strategies were wonderful. The messages were out there. The healthcare workers were told to improve on their attitudes, and we feel that with all this working, that people are more willing. Let's see the numbers as the months go on. Thank you.
Thank you very much. So as we are getting ready to close, we wanted to launch a quick poll for those of you who are joining us here, and we're asking, how well did the findings that we've presented here resonate with your experience on catch-up efforts in your setting? Do they resonate very well, somewhat well, or not well at all? One of the things that we recognize is these are case studies. We don't expect the findings to be generalizable, but we do hope that some of the lessons are transferable to other settings, so that we can take lessons from these different experiences. So I'm going to leave the poll open for just a few more seconds while we get ready to do the closing remarks. And I want to take this opportunity while we wait, while folks vote, to just once again note that we will have in-depth, and when I say in-depth, it's pages and pages and pages of individual case study reports, as well as global case study reports that have all kinds of data to walk you through how these efforts were planned, implemented, and monitored in these different countries. What is happening with institutionalization, and then also what are the factors long-term that make kids miss doses, and how can those be addressed? So I'm going to stop here, and I'm not doing this to be biased. So I'm going to assume that everybody who wanted to answer did, and you see that most people are saying that these findings resonated well with their setting, even though about only 45% of you responded. So I'm just going to assume that this is not a biased sample. And so it sounds like there is at least a little bit of reflection there for you. So I'm going to close this now and turn it over to Stephanie Schendale, who is going to provide some concluding remarks. And give me 1 second while I get this going. Okay. All right, Stephanie, you should have control of the screen. Please go ahead.
Thank you so much, Daniela. It doesn't seem to be, oh, there it is, moving for me. Okay, perfect. So first, I just want to thank everyone again for these amazing, amazing, insightful presentations today. This was also my first time getting the debrief from many of these case studies as I was away during the pre-briefing. And so I was coming at this as a fresh audience member as well, and super encouraged to see all of the incredible findings that are coming through that are really bringing out the granularity and how this large initiative was implemented at the country level. The learnings that are going to come through from these are going to be so helpful for not only being able to better communicate the impact of the big catch-up, but also to help other countries as we move forward into the institutionalization phase of this into next year, and really continuing to promote the importance of establishing catch-up as part of all routine systems. It was really encouraging to see that across the board, every one of the country case settings came out very strongly with the desire and the recommendation that this should be part of ongoing routine immunization systems. And in fact, the only real way to be able to sustain catch-up vaccination in the long run is to do exactly that and make sure that it is embedded in the system. Of course, there are a lot of challenges still, and those were really clearly coming out in all the case study findings, but they do mostly relate to the systemic challenges that we face for routine immunization system in general, and reaching zero dose communities and making sure that we're getting every child and every adult, in fact, as we move towards a life course approach with access to the vaccinations that they deserve. And so, of course, intensive investment will still be needed to strengthen systems accordingly, but it's encouraging to see that there's broad buy-in across all stakeholders that this should include a vision of catch-up vaccination as part of that as we move towards a life course approach. And so I just want to make sure that you're familiar with the resources that are available, and that WHO and all the alliance partners are here to support country efforts as this continues, as this strengthening of routine systems with a catch-up lens continues. And so we have the big catch-up community on TechNet. If you're not already a member of that group, please go visit at the link in the slide works, and maybe someone can jump it into the chat. This has all of the resources for the big catch-up, including an institutionalization checklist that we've developed to try to help pull together a lot of these key considerations in what should be in place from a systems perspective when we think about integrating this into routine systems going forward. We also have a landing page at WHO dedicated to catch-up vaccination, where all of our resources on embedding catch-up into routine systems and establishing catch-up schedules and policies can all be found. So the links to those are there. And if we have time, I'll just flash up one more slide that highlights some of the resources that WHO and partners have developed to support countries in this. I put the French slide up because our Francophone speakers have been going through English slides this whole time, but all of these resources are available in French and English, and in many cases, additional UN languages, Arabic, Spanish, and in some even in Portuguese. So please do visit the links on this page, and always feel free to reach out for additional support needed in moving forward to the next step of this initiative. And with that, I'll turn it back to Daniela.
Thank you so much, Stephanie. So we appreciate everyone's time. It is, we also want to acknowledge gratefully the support from all of the local country stakeholders that supported these studies, the support from our WHO country and regional office colleagues, and most importantly, all of the study participants that gave so generously of their time, from the highest level government officials to the local level families and caregivers all across the board. And it's important for us to acknowledge that our overarching work at the Alliance is supported. We benefit from long-term support from the Swedish International Development Cooperation Agency, as well as the Norwegian Agency for Development Cooperation. This particular work received generous support from the Gavi, the Vaccine Alliance. And with that, we thank you so much for your time. Please look out on TechNet for the recording. It will be made available, and I believe a link will be sent to all of those of you who registered for the webinar. Thank you very much, and have a great rest of your week. Bye-bye.
Bye-bye.
Bye.
Thank you.
Bye, everyone.